This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, everybody, and thank you for joining us for our HealthyU Webinar Series. Today's topic is screening patients for cancer of the colon and rectum. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We will answer as many questions as we can within the time allotted once the presentation concludes. Your questions will remain anonymous. And today's presenters, I'm bringing you Dr. Kadash and Dr. Khurana. So, Dr. Khurana, whenever you're ready, the floor is all yours.
All right. Good afternoon, everyone. My name is Dr. Khurana. I'm one of the GI fellows at Mather. Just give me 1 second to pull up the slides. All right. Let me know if you guys can see this.
Yep, we could see it.
All right. So today we're going to be talking about the importance of screening patients for cancer, particularly of the colon and the rectum. It'll be presented by myself and Dr. Kadosh, who will be joining us for the latter half of the presentation. So the goals of screening, you have to figure out, one is, what are the criteria to determine if a disease is a good candidate, if a patient is a good candidate for screening? This factors in what their age is, a detectable preclinical period, and this is generally before the disease is already spread too far and the treatment won't really be beneficial. Treatments are beneficial if you catch it early, which is why screening early is very important. And actually, the guidelines now recommend anyone age 45 or older be screened. So this is the patient population we tend to target. So what is the criteria for a good test? When we're looking at testing, we look at the sensitivity and the specificity of testing. So sensitivity is the ability for the test to detect everyone with the disease, and specificity is the ability for us to exclude those without disease. A high predictive value test means it's efficient and you're more likely going to get accurate results. You want a test to be, minimally invasive, safe, and of low cost to the patient. So some of the adverse effects from screening, you can get discomfort from procedures. Generally, that's typically just, gas pains post-procedure. There may be more serious complications. Those are generally rare. Long-term radiation effects, if you're using repeated CT imaging as a choice for screening. You can get a lot of false positive tests as well, particularly with the stool-based testing. And risk of pseudo disease. This is where basically you're over-diagnosing cancers that are not significant or those that are not really curable because it's such an early stage. So let's talk a little bit about colorectal cancer. This is cancer of the lining of the colon, also known as the large intestine and the rectum. The factors that influence this are both genetic and environmental, and we're going to touch a little bit about those later in this talk. 90% of cases occur after 50, although now we're even seeing it in younger patients, even in their 30s, and that may be due to a lot of different things such as our diet. And the overall 5-year survival rate is approximately 61%. So when we do a colonoscopy, we generally start, you guys can see the picture of the colon here, but we'll go all the way from the rectum all the way into the ascending colon, and it's a thorough evaluation of your whole large intestine. So colorectal cancer, mostly it's asymptomatic in the early stages. The common complaints we generally see, which kind of prompt us for further evaluation, includes constipation, weight loss, rectal bleeding, anemia on labs, particularly iron deficiency anemia, and lower abdominal pain. So how does colon cancer spread? There's multiple stages, stage 0 being the least invasive to stage 4 being the most invasive. So stage 0, the cancer cells are mostly in the lining and they haven't spread further. And then stage 1, the tumor is spread beyond the inner layer, but it's still in the colon, as you can see in these pictures. And once it reaches stage 2, it's grown outside the colon, but it hasn't gone to the lymph nodes. And then stage 3 and 4, it spreads into the lymphatics and throughout your body. And at that point, it's more the treatment changes in terms of how aggressive we have to be. That's when you start talking about chemo and radiation. So just like in cardiovascular disease, there's also modifiable and non-modifiable risk factors for colon cancer screening. So the ones that are non-modifiable are, as you get older, your risk of colon cancer goes up. There's also, race and ethnicity can play a role in colon cancer. And, genetic factors, meaning do you have mutations in certain genes that lead to more predisposition to getting cancerous polyps and such. The modifiable risk factors are smoking, physical inactivity, obesity, and things such as that. So we're going to touch a little bit about these later in the talk, but the goals of screening are, again, is it detectable in the preclinical period? We want to make sure we find the patients before they develop colon cancer. And if we do find that it's a colon cancer, can it be cured early? And the treatment is more effective. Is treatment more effective earlier on in colon cancer patients? And is it colon cancer common in the common population? And we'll talk about that. So I wanted to touch a little bit about the different testing. There's stool-based testing, and then there's structural examinations of the colon. So the stool-based testing includes your FIT test, which you get every year. You can get a fecal occult blood test every year. And you can also get a multi-targeted stool DNA test every year. The other exams you can have is a colonoscopy, which we kind of went over. That's done every 10 years, but it can be done sooner based on how many polyps someone has, a family history, or if the polyps are, more cancerous in nature based on their pathology. You can do a virtual colonoscopy, which is a CAT scan-based imaging test every 5 years. And you can also do a flexible sigmoidoscopy, which is basically you don't go through the whole colon, but you're going past the sigmoid part of the colon. And I wanted to touch a little bit about, we were talking about sensitivity and specificity. So the sensitivity or the ability to pick up disease, or if we wanted to find colon cancer, for colonoscopies, studies have shown that's up to 95%. All right. And then I just wanted to touch about these other tests, like the FIT test, the sensitivity to detect colon cancer is only 73%. And even the multi-targeted DNA test, your sensitivity for that, it's better, it's 92%. If these tests come back positive, you are still going to need a colonoscopy. These are tests are picking up changes, but there's no way to act on whatever is causing those changes. That's why colonoscopies are so important, because you can both diagnose and treat. So is colorectal common? There's 150,000 cases per year in the US. 110,000 of those are colon cancer, and the remaining 40,000 are rectal cancer. About 9% of all cancer deaths are due to colorectal cancer. The lifetime incidence is about 5%, and 40 to 50,000 deaths per year are due to colon cancer. And you can see as your age goes up, the rate of developing colon cancer goes up, which is that's very important to get early screening. So how does your nutritional health impact the development of colorectal cancer? We've learned certain risk factors, especially in our diets, increase your risk. So consumption of red meat and processed meats can increase your risk of developing colorectal cancer. Increased alcohol consumption can lead to increased risk. Being overweight and obese also increases your risk, along with decreased physical activity. Things that decrease your risk are having whole grains and foods high in fiber. Other things include having adequate calcium and pre and postbiotics. They can help decrease your risk as well. So red and processed meats, this includes beef, pork, veal, lamb, and goat. Processed meats are things you have at the ball game, like hot dogs, bacon, sausage, corned beef, beef jerky, canned meats, cured deli meats. They think that the process of salting, curing, and fermentation or smoking, they enhance the flavor and improve preservation, but it was these processes that lead to creation of nitroamines, which have been classified as carcinogenic. And this is why we believe you have higher risk of developing colon cancer with these foods. 50 grams of processed meat daily is shown to increase your risk of developing colon cancer. So that's 3 slices of bacon, for example. 18 ounces, 18 ounces or more of red meat weekly can also decrease your risk of developing cancer. All right, sorry. Okay, so alcohol consumption. Higher the alcohol consumption, the greater the risk. Most alcohols contain ethyl alcohol or ethanol, and these are linked to many cancers, including colorectal cancer. When you break down ethanol, it forms a substance called acetaldehyde. This can damage cells in the DNA, particularly in the colon and the rectum, and this is how you get development of cancer cells and tumors. So the guidelines recommend limited alcohol consumption, no more than 2 drinks per day for men and 1 drink per day for women. High sugar intake is another risk factor. Recent study shows that increased consumption of processed sugar can alter the gut microbiome, leading to bad bacteria and decreasing the good bacteria in the digestive tract. High dietary sugar can lead to excess energy consumption, leading to weight gain and obesity, which, as we know, is a risk factor for this disease. So you should really limit high fructose corn syrup and added sugars. We recommend to limit added sugar up to 26 grams or 6 teaspoons per day. So how does obesity and colorectal cancer come into play? You can see excess body fat can cause long-lasting inflammation, increased levels of insulin or insulin-like growth factor, and these lead to the development of cancer. Fat tissues respond less to insulin, leading to increased levels in the blood. High levels of insulin can promote cancer cell growth. Research has actually shown that decreasing your body weight by even 10% can help lower insulin levels and reduce the risk of cancer development. Physical activity, we all know it's very beneficial to numerous things, and such as controlling blood pressure. And the main goal is you want to assist with weight loss and weight maintenance. When you're exercising, you use more energy and you burn more calories. How does this improve gut health? Those who are more sedentary have a different gut microbiome compared to those who are active. So this is why the CDC recommends at least 150 minutes of physical activity per week of moderate intensity, such as brisk walking, water aerobics, bicycling, easy jogging, dancing, and at least 2 days a week of resistance training with weights, or even using your body weight or resistant bands. So the gut microbiome is a collection of basically microorganisms that live inside your gut or in a specific environment. The influence on this are, of course, it's your digestion, your immunity, insulin resistance, which is dependent on how active you are. And those who have pre and probiotics have been shown to have a decreased risk of colorectal cancer. Probiotics are bacteria that balance the good and the bad bacteria in our gut. Things rich in probiotics include yogurt, kimchi, pickles, kombucha, and sauerkraut. Prebiotics work with probiotics, and they're mostly found in fiber-rich foods, and they act as a source of nutrition. You can get prebiotics in garlic, onions, bananas, soybeans, whole wheat, and whole grain products. So why screen for colon cancer? There is definitely a detectable preclinical period. Colon cancer is derived from colon polyps. This is why we do the screening. If we see these polyps, we can remove them before they can become the cancer. And colon cancer is one of the few cancers we have that we can intervene before it becomes a cancerous lesion. So that's why screening is very important. So colon polyps are precancerous growths in the colon, and when you do a colonoscopy, it looks like this image here. They occur in roughly 25 to 30% of people at age 50. And as high as 50% in age 70. So if we see these, we take them out. And we're going to talk about that later in this talk. So only 1 to 4% of people in their 20 to 30 have colon polyps. The incidence increases with age. We're seeing now, that's why the guidelines have changed, that we actually do screening earlier at age 45 because the incidence of these are actually rising. And this is likely due to our diets and other factors. So the developing cancer can happen in as much as 7 years. 90% of colon cancer deaths are thought to be preventable by early detection. Just hammering home the importance of screening. So the life cycle, you can, it's an orderly progression. So this is a normal colon on the left. In the middle, you can see here a polyp, or what's called an adenoma, a precancerous lesion. Let's say 10 years go by and you don't get a colonoscopy. This lesion, this polyp, can become a cancer. That's why it's important to, if you have polyps, they're removed, and that changes how frequently we're going to do a colonoscopy. So as I mentioned, colon cancer can be prevented by removing these polyps. And we have multiple tools to do this. We can use forceps here on the left, or we can use what they call endoscopic snares on the right. And now we're going to touch a little bit about does polypectomies work, and I'm going to hand it over to my colleague, Dr. Kadosh, to take over.
Hi there. Thank you, Dr. Karana. Sorry for joining a little bit late. My name is Dr. Kadosh. I work here at Mather. Just having a little bit of computer difficulties. Is there any way that we can upload the slides that we had sent? Is Jonathan on?
Yes, I'm.
Okay, I can stop sharing my screen if that's easier for you, David, or Dr.
Yeah.
Kadosh. Okay.
Computers.
So just confirming, Dr. Kadosh, you're going to share their screen?
No, do you have the PowerPoint loaded?
I do, yes.
Yeah, that'd be better. Just having PowerPoint issues. Yep, perfect. We can go to, I think it's slide 24. All right, so just to continue on what Dr. Carano was saying, of course, we know that colonoscopies do prevent cancer, but what is the data behind it? So this study in the famous New England Journal of Medicine was first published in actually the 1970s and then reevaluated in the 1990s, 1993, and there was actually a 50-year update in 2012. And you can go to the next slide. And it actually really gives us the basis for kind of proving to our patients and to societies and insurance companies, of course, of why we do these procedures. So it looked at different databases. It looked at about 1,400 patients who had underwent a complete colonoscopy and had any sort of polyps removed. These patients were followed for about 6 years, and the incidence or the expected number of cases, the found cases of colon cancer, was significantly reduced in the population in patients who had had any sort of polyp removed. So this polyp, what we call polypectomy, the removal of polyps, resulted in a much lower than expected. You can see percent reductions of close to 90% reductions in different databases in the incidence or the appearance of colon cancer. Next slide.
Sorry, I'm just going to fix something really quickly.
No problem.
Error on my end.
So we can go to the next slide. So the results from this study, you can see that the observed incidence, the observed new patients that were found to have colon cancer at the 6 to 7 year follow-up, which is the single black line, was much reduced from the patients that were expected. These are patients in databases who had not undergone these procedures. Obviously, it's hard to randomize. Usually the best studies that we perform in medicine are the ones that we can say we'll do one thing to one group and one thing to another group and see what's the difference. Here, because it's standard of care to do these polypectomies, it's hard moving forward to kind of prove the relationship. But looking backwards, we've really been able, especially with the 50-year data from 2012, we've really been able to show that there is a significant reduction in colon cancers by doing these procedures. Next slide. So is earlier better? Normally, yes. In this case, definitely so. So where we find the cancer at what stage really determines not only if you can get the cancer out, but overall mortality. So the staging is numbered 1, 2, 3, and 4. With these modifiers, we have a TNM, which is the extent of where the tumor goes, if there's any sort of involvement of surrounding tissue, and finally, if there's any distant tissue that's involved, which is called metastasis. So where we find the polyp in our colonoscopy at what stage kind of determines if they can just get a simple removal of the polyp, a removal of the cancer itself, whether endoscopically or surgically, or if the patient needs to undergo any sort of chemotherapy or radiation. Next slide. So this is the TNM staging in a more graphical picture. You can see that when it's stage 0, 1, or even 2, it's really kind of localized to the colon itself. We can easily use different techniques to take out that tumor without having the patient undergo any sort of invasive surgery or any sort of chemo radiation. Once you get to stage 3 and 4, unfortunately, that's when the tumor starts to get these blood vessels. It starts to invade into distant organs, and that's when we have a much tougher time controlling the disease. Next slide. So the 5-year survival is directly dependent on where at what point we find these cancers. So you can see based on the stage, your survival unfortunately does go down, where by the time you're at stage 3 or even 4, where we consider metastatic disease, your survival is down to almost 8 to 10%. The rectal cancer data is fairly similar. You can see that depending on the stage, you really want to catch these things as early as possible. That gives us the best chance of helping patients and improving mortality. Next slide. So the different methods. So anytime you come to the doctor, or anytime we advise someone to undergo a test, we need to give them alternatives, because there are, and we want everyone to be as informed as possible. So the simple things we can do are non-invasive, and then it goes from non-invasive to stool-based testing to blood-based testing, which we have now, and then imaging, and then finally the colonoscopy, which is the actual procedure. I will preface most of these things by saying that you really need, if any of these things are positive, to end up with a colonoscopy. So the simple thing we can do is in the office, check your stool for any sort of microscopic blood. A lot of times patients don't see blood, but it can be there microscopically, and we pick that up on these cards that you see on the right. There are special stool tests called stool DNA that you see at the bottom. That's where we send the stool for a special DNA analysis. If there's a tumor, if there's an advanced polyp, it sheds these DNA particles that is picked up. And that test does have some utility, some use in the community, especially with patients who are at average risk, don't have any family members, don't have any history of polyps, and patients who are sometimes too sick to undergo any sort of invasive procedures unless absolutely necessary. Other things we can do, less used these days, is a barium enema, which is injecting contrast through the colon. A virtual colonoscopy, you'll hear a lot about that. That's basically a CT scan that can detect polyps in your colon, but only if the polyp is about 8 millimeters or larger. There are polyps that are less than that. The issue with the CT colonography, for anyone who's undergone it or for anyone who's heard of it, is that you still, first of all, need to go through the preparation. You still need to drink all of that liquid. And second, there is a rectal contrast component where it's an uncomfortable kind of insertion of contrast through the rectum. So that's why some patients really don't prefer that type of test. A flexible sigmoidoscopy we rarely do as well. That's where we basically do half of a colon. So you still have to prep, you still have to drink everything, but we don't make it to the very end. That's in patients who maybe don't want as much anesthesia, don't want all that sedation. And then you have colonoscopies. Next. So the colonoscope itself is what you see on the right. It's a flexible fiber optic cable. At the end of the scope, there's all these lights. There's a channel for us to insert instruments through, and there is a empty channel that you see on the bottom, and that's for suctioning any sort of liquid we see to help clear the area. The scope is very flexible, it's flimsy, and it can reach all the way to the areas that we want, and we control it from the outside with the knobs and dials that you see on the top right. Next. So what are the issues that we really kind of, why is everyone not getting a colonoscopy? And there's a couple. I would say one and foremost, it's the preparation itself. Patients and people don't really want to drink all of that liquid, don't want to have to rush to the bathroom all evening long. It's not comfortable. The procedure itself is not just, it's not uncomfortable. You are asleep, you're sedated. When you wake up, you wake up within about 5 to 10 minutes. So the pain aspect is not as much. In the past, people used to use regular air to inflate the colon to look better. But nowadays, we actually use carbon dioxide, CO2, and that inflates the colon really well. But the benefit is that it then gets dissolved easily. So it doesn't stay in the colon. It doesn't make you very distended and bloated. Next slide. So the preparation itself, obviously we need the colon to be as clear and as clean as possible so that we can see all of the walls, inspect everything. So the day before, we actually have patients go on a clear liquid diet. And this is basically jellos, broths, soups, water, Gatorades if they're clear. And this is to start the process of cleaning the patient. There's no solid food the day of the procedure. You start with a laxative, usually around 5 p.m. Sometimes, depending on the office you go to, they add oral laxative, earlier in the day. And then you start drinking the preparation around 5 p.m. You have loose stools until your colon is fairly clean, and you start to have stools that really almost look like urine colored, very dilute, watery stools. Next slide. So in the past, the preparation was called Go Lightly. It's this very enormous jug of clear liquid. It was really not well tolerated. Sometimes people used to do fleet enemas plus this Go Lightly. We rarely use this anymore unless you're in a hospital setting because of how much fluid and how the taste of it was really unbearable. So next slide. So the newest preparation, we have over-the-counter options. We have prescription options. We used to use Miralax, which is everyone knows kind of to go to the bathroom, you take a little Miralax. We used to tell patients to take the entire jug over the course of an evening, and you can mix it with your favorite non-red liquid, ideally. And this is pretty well tolerated from patients, but we have an even better option now. Next slide. So now we use what's called Suprep. It's a version of Miralax that's prescription strength. So it's these 2 small bottles. They have 6 ounces each. They contain sodium sulfate, potassium sulfate, and magnesium sulfate. The only patients who really cannot take this are patients who have chronic kidney disease to a certain degree. They need to have pretty bad kidneys for them not to take it. Everyone else it's well tolerated. It gives us a really good, clean picture of the colon, and it doesn't have as much of the nausea and vomiting that's associated with historically the preparations. You do mix it with a good amount of water. So on the day before the colonoscopy, you mix the bottle with 30 ounces of fluid. And then 6 hours later, which is about 10, 11 p.m., you do another 30 ounces of fluid. After midnight, you stop drinking and eating. Some offices, depending on what time your procedure is the next day, will have you actually take 1 bottle in the evening and then wait till the morning to do the second bottle. But it just depends on the office. Next slide. So the exams are done. The colonoscopies, kind of start to finish, are about 15 minutes, depending on what's found, sometimes a little bit more. You usually have IV sedation by an anesthesiologist or a CRNA. You're sleeping, you're breathing on your own. Sometimes we have patients who don't even remember going to sleep. Right now, the main standard of care is using propofol, which is an IV sedative that is well tolerated. And the good part about it is it's quick on and off. Once you start giving it, it works great. If the anesthesiologist stops giving it within 2 to 3 minutes, you're basically back and you're awake and with no lasting side effects or grogginess. We monitor all vitals while you're under sedation. So what your oxygen is doing, what your blood pressure, your heart rate, you're continuously monitored. during the procedure, before and after, by the anesthesiologist. Next slide. So the goals. So we want to find basically any sort of polyps, not just colon cancer. We're looking for polyps so that the earlier we take them out, the better. And the fact that they won't grow into becoming something that we don't want them to grow into. So can colon cancer be cured early? Yes. By taking out these polyps, if they are precancerous, then we prevented the colon cancer from developing. If they're low-grade cancer, we prevented it from becoming high-grade, and so forth. So the earlier we catch these, the more survival, the better the treatment options are, the less invasive the surgeries and options become. Next slide. So the current guidelines are that they were recently changed. So 45 is the new 50. So this guideline is actually a little bit outdated as of a year, 2 years ago. So any average risk person, meaning a person who does not have any first degree family relatives or more than 2 second degree family relatives, is considered average risk. Anyone with a history of a polyp or anyone with a history of a positive stool test or any of that is not considered average risk and may need to have their colonoscopies brought up sooner. So we start at 45. If you have a family member or something, we make adjustments based on that. And at 45 is when we start any sort of test. So whether that be a colonoscopy, which is the preferred test, or the stool-based testing. So I'm not even going to talk about flexible sigmoidoscopy because we really advise against it. So you could do a CT every 5 years, or you can do a annual stool test that looks for blood, or you can do the DNA stool test that we talked about every 3 years. Again, if any of those non-colonoscopy tests turn out positive, you're stuck doing a colonoscopy. Next slide. So unfortunately, in the US, less than 60% of those above the age of 50, which now will be 45, have really received appropriate screening. So we're missing a big chunk of the population. But the good news is, with more awareness, with more talks like this, with more national kind of publicity, unfortunately, celebrities who have colon cancer and talk about it more on social media or via the news, we are getting more people who come to us who have never had a colonoscopy. And not only are they 45, 50, but sometimes in their 60s and 70s. You know, I've never had a colonoscopy. I really want to get one. But it could be better. We could be doing better. And that's what we strive for. Next slide. So the colonoscopy itself is done by people who have gone through a lot of training, who have gone through medical school, residency, fellowship, sometimes a sub-fellowship. So you are in good hands. And it's really the only test, the only screening test, if you think about it, that's not only diagnostic, but therapeutic. So we're looking for things, but we're not only looking. If we find something, we can do something about it, which is the beautiful part about this field. Other options, do have a role. There's a new field now in blood-based testing where you can get a blood test that shows if there's circulating DNA. The data is not as strong as getting a colonoscopy, but it's not too bad. But again, if someone has a positive test, they still need to undergo that colonoscopy. Next slide. So we do have a direct access program here at Mather. This is the number. This is for people who are average risk, like we talked about, no family history, no significant cancers in the family, never had a colonoscopy or have had one and have never had any polyps. These are the people, and most importantly, who don't have significant medical problems. So they have a little bit of hypertension, some cholesterol, but that's really it. If you're taking a lot of medications, or if you feel like you've been seeing the doctor, your primary care doctor often, ask them, am I a good candidate for a direct access? What this means is that you call this number, you schedule a time to come in, and you skip that initial visit with us in the office. The first time we see you is at the surgical center or at the hospital to do your procedure. Next slide. So the key takeaways, like Dr. Khurana said, there are ways to reduce the incidence or the formation of colon cancer. And this is to maintain a good body weight, to increase your physical exercise, to eat less red meat and processed meat, eat more fish and plant-based, limit our alcohol, increase fiber-rich foods, have a good calcium and vitamin D intake, probiotics, prebiotic rich foods and meals. If we do that and we get our appropriate colon cancer screening, we're doing good. Next slide. The best test is the one that gets done. And, any gastroenterologist, I think, will agree with that statement. Next slide. So that's it for us. We'll take questions, if anyone has any, if anyone needs any clarifications.
Yes.
Yeah.
Thank you so much, Dr. Karana and Dr. Gadash. And yes, if anybody has any questions, you can enter them at the Q&A feature at the bottom of your screen. All questions are anonymous to protect your privacy. So we'll give it a few moments here to see if anybody has anything. Let's see. It doesn't look like anybody has any questions. But if you do have any questions that maybe come up later on in the day, you can email them off at matherhospital@northwell.edu. And if you'd like to view past HealthyU webinars, you can see them at www.matherhospital.org/healthyu. Thank you so much, everybody. Thank you again, Dr. Karana and Dr. Kadash, and I hope everybody has a great day.
Thank you very much.
Thank you.
Have a great day, everyone.